Welcome everyone to the first Health Campaign Effectiveness Coalition webinar of 2024. It's been a while since we hosted a learning event and we're so pleased to be starting this up again. Thank you all for your participation. Over the next 90 minutes, we will hear from the HCE Program Director with a brief intro into the coalition and overview of our latest progress and strategy for the coming years. Then we'll get a deep dive into an interesting analysis and new tool that's been developed by Linksbridge to help us identify potential campaign co-delivery opportunities. And we'll conclude with a participatory discussion on campaign integration, co-delivery and opportunities and potential applications for tools that can help us all be more effective. My name is Chichi Amadi, and I am the Senior Associate Director for Global Health Policy at the Task Force for Global Health HCE program. I am joined today by my colleagues, Chris Salas, the HCE Program Director, Andy Tokosin, and Eric Osland, Data Scientists at Linksbridge, and India Bose, Team Lead and Vaccine Preventable Disease Surveillance and Risk Assessment at IVB-WHO. I'm Pratima Raghunathan, the Deputy Director for Programs, Division of Global HIV/AIDS at CDC. And India and Pratima are also the co-chairs of the Disease-Specific Initiative Working Group at the IA 2030. Just a few housekeeping rules that we would like to point out today. We want this to be very engaging, and we are here to answer your questions and hear your inputs as well. Please use the chat to introduce yourselves and the Q&A function to post questions to the presenters. Later on, we will use Mentimeter for a very engaging discussion, which you can participate in by using your smartphones or computer. Great. Now let's begin. I'm going to hand it over to Chris.
Thank you, everybody. Good morning and good afternoon. I am Chris Sarlis. I am the director of the HCE Coalition, and I'm really delighted to have all of you join us today. I know many of you have joined us for past events, but for those that are participating in their first HCE Coalition event, I thought I'd share a short introduction of who we are and also introduce our new strategy. First slide. The HCE Coalition began in early 2020 to address one of the biggest challenges facing health programs today. Over the past decades, you've seen the initiation of a number of disease-specific initiatives, which in turn have resulted in a significant reduction of disease mortality and morbidity. That's the good news. However, as you also know, most of these initiatives or programs have very specific donors with their own set of financing, targets, and goals, which unfortunately has also created some fragmentation and competition among our various different health programs, often making it very difficult to collaborate or coordinate our work towards those shared goals. Next slide. So 4 years ago, the HCE Coalition came together to address this challenge with leadership from across several different global and regional organizations. You can see the icons here on the slide, donors and also country partners across the 5 major campaign domains of immunization, polio, malaria, neglected tropical diseases, and nutrition with vitamin A supplementation. We are all working together towards a shared vision where countries are really driving the decision-making process around campaigns and using a strategic balance of campaigns along with routine primary healthcare services to achieve their health goals. During this time, we have worked together to strengthen our communication, and we've shared tools and lessons learned across the various different siloed campaign programs. We've also funded 20 implementation research studies in 15 different countries that surfaced a number of promising practices around campaigns, especially around campaign integration. And we can put the link in the chat a little bit later, and you can find copies of all of our studies and reports on our HCE website. And in 2023, we came together and we synthesized and compiled all these learnings and recommendations into a new strategy for campaign effectiveness, We call this the Collaborative Action Strategy, or CAS. Next slide. The CAS is intended to complement existing campaign programs strategies by providing a set of recommendations to country, donors, global and regional organizations, and how to work together more effectively. A large number of coalition partners were engaged in the development of the process of the CAS over the last several months over last year. And then the strategy was approved by our coalition leadership team in just December this past year. You can find the CAS on our website, along with a slide deck and a 2-pager that explain a little bit more about the CAS and its purpose. We're also pleased to say that the Ministries of Health in both Nigeria and Ethiopia have agreed to be the first focus countries. They're just beginning this work right now to review and adapt the CAS to their own country context. And in the coming months, we'll be sharing on probably some future webinars their progress. Next slide. When you read through the strategy, you will see that there's a set of 12 recommendations that cover 3 broad areas with guidance on how to collaborate on campaign planning and implementation, MRLA, or M&E, which stands for Monitoring, Evaluation, Research, Learning, and Adaptation, and also on campaign financing. I'm not going to read through each one of these, and they're probably a bit small on your screen as well. But they're all in the CAS and you can go through them afterwards. But I wanted to highlight one of the very first recommendations on collaborative planning, which has relevance to our webinar today. Recommendation, it's numbered 1B here, calls for countries to work together through an analytical process to identify which campaigns they can collaborate or integrate on. And we know this is no easy task, and one that requires a variety of different factors to be considered, especially if you're planning to do any co-delivery of 2 different interventions. I think we can take the slides down. Thank you, Allie. So we're pleased to have partnered with Linksbridge from the very beginning of the coalition. They developed the first global health campaign calendar, which you can find on our website, and it's also now become a very robust campaign intelligence hub, which has almost 5 years of campaign data in it. In addition, the coalition has been a member of the IA 2030 DSI working group, which is also addressing opportunities around immunization integration. We're excited to bring them together today to share the collective work. And now I'll turn this over to Andy to launch our presentation. Thank you very much.
Thanks, Chris. So what we'll talk through today is a presentation of a description of an analysis that we completed about missed campaign integration opportunities. The work here was to develop an algorithm to identify the potential integration opportunities in 7 countries between 2019 and 2023. So what we'll go through in this presentation is the overall, the background and the context for the analysis, our purpose and the objectives that we tried to meet through the analysis, the way that we approached it and our overall methods. We'll go through results and then the key takeaways, talk through limitations, any requests at the end, and then talk about next steps, and then go into a discussion where we'll have a Menti poll near the end. So from here, what I'll do is I'll hand it over to my colleague in India to talk through the background, the context and rationale behind the analysis.
Okay, thank you, Andy. I hope I'm audible, and hello, everybody. Good morning, afternoon, or evening. I don't know whichever time zone you are. I mean, it's afternoon here in Geneva. And thank you all of those who are attending and those who have organized this. So all of this work that we will discuss today, you'll listen and we will discuss together, is anchored in IA 2030, which is the acronym for Immunization Agenda 2030, and most of you will be familiar because it is for this decade, 2021 to 2030, that it's an immunization agenda. It is not organization specific. It attempts to capture and put together and move together towards improving immunization coverage. It has 7 strategic priorities. I'm not going to read through all of them, but you can see that there's a continuum of strategic priorities. and 4 core principles for action. And those 4 core principles, it is good to repeat them. They people-centered, country-owned, partnership-based, and data-guided. These are the 4 core principles. And we are being guided by this in WHO, UNICEF, CDC, all other organizations, philanthropic organizations that are in this game, so to speak. Next one, please. So what is new in IA 2030? You will see there's 10 sort of icons, which is global level partnership, integration into universal health coverage and primary healthcare, UHC and PHC. It is co-developed and co-designed by countries, regions, and global partners. It is tailored M&D framework. That means we know one size doesn't fit all. So each country or a different sets of countries may need different kinds of monitoring strategies. Addresses immunization coverage and equity, stronger system focus, gender-based barriers. We have now realized that gender is an important indicator of equity or lack of equity. Strives to strengthen partnerships, but for today's discussion, it had already envisaged integration of disease-specific initiatives, of which Pratibha and I are the co-chairs, because we know these disease-specific initiatives have given us a lot. I mean, smallpox was one kind where the one only known disease has been eradicated. After that, there's polio, there is measles, there are other diseases, many of them, and they bring deep domain knowledge in this game. But this is a time now to integrate those specific deep domain knowledge and maybe move towards more integrated campaigns and more integrated public health. Next slide, please. So campaign integration, therefore, as I said, is anchored into 2030. And many of these vaccine preventable diseases have targeted focus on pathogen and disease. And these groups, as I said, have strong domain knowledge and strong practical knowledge. And we thought that greater operational efficiency, that is IA 2030 thought that greater operational efficiency and greater sustainability also can be achieved if we integrate them, integrate their different expertise, their domain knowledge, their operational experience. And however, we found that they're limited, if any, operational guidelines or standard operating procedures, how to do it. Even if we all accept that integration is a good thing, then how do we do it? So therefore, an IA 2030 in-depth review IDR on campaign integration has been in progress and is nearly completed, which Chris spoke about. And in the present part, we report on a data-based approach. So this builds into an overall collaborative action strategy towards campaign integration. But let me make it very clear before we delve into deeper details of this, that this is only a database tool. And by campaign integration, what we mean that integration of 2 or more campaigns. I mean, it may be a non-immunization intervention-based campaigns also, but at least one of them would be an immunization-based campaign. And the integration can range from integrating single components like planning or supply chain to the whole range of co-delivery of the services. So there's a whole spectrum of campaign integration. Ideally, it is a co-delivery of services. It can be less than that also, depending on the circumstances. Next. So the purpose of objectives of today's presentation, as well as the work that we have done, is that we try to identify potential missed opportunities. That means this is looking at the past in different countries, which Andy will be describing, to identify potential missed opportunities for campaign integration from retrospective data. And using that data, retrospective campaign data and data method, to identify campaign characteristics that will facilitate or hinder integrated service delivery. That's what we have tried to define. And we have also tried to develop a user-friendly analytic method that can be further adapted and applied. And at the end of the seminar today, we will be seeking inputs from, I can see already the attendees and some of the names are familiar to me, but we'll seek inputs from you all who are attending today about usefulness and willingness to apply these tools in country context so that it doesn't become only a document, only a tool which is up there and not applied. So we'll try to understand from you how applicable it will be, how it will benefit you. Over. Next slide. over to you, Pratima.
Thank you so much, Anindya. It's a pleasure to present. And here we are just talking about our general approach to this analysis, which was to a retrospective analysis of all the historical campaigns available in the Health Campaign Effectiveness database. And so our approach, excuse me, was to analyze all the possible combinations of campaigns from 2019 to 2023 within some selected focus countries to identify those that were feasible for campaign integration. As you'll hear further, the matches were ranked based on compatibility, and there were some optimization techniques used to suggest the best combination of matches. So this is a data science approach to think about what might be possible campaign integrations, irrespective of looking at the data in the database. And our future hope with this analysis is to engage countries and understand further how this analysis might be refined. Might there be additional opportunities to model impact of campaign integration, including impacts with costing and on coverage? And also, could we potentially tailor the algorithm using prospective campaign data? Ultimately, would this analytic supports tool, the decision support tool, be useful for countries? And could it be integrated into the collaborative action strategy package of materials that are being developed by the Health Campaign Effectiveness Coalition? Next, please. So the retrospective analysis that was conducted uses the campaign hub collates many data from many of your partner organizations and uses data from across 36 interventions and 20 diseases. And I think many of you are familiar with the Health Campaign Intelligence Hub. And yellow on this slide indicates where more frequent information updates may help make the database more timely, complete, and useful. And this is just an example of the types of data. You can see different diseases as well as from different partners and the different ways that data are being collected. Next slide. So when we applied the country and campaign selection criteria, we ended up with 240 campaigns in the analysis. And so just to go into this a bit in detail, for the analysis, we chose to focus on 7 countries listed on the left, and they represented different archetypes from Africa, from the Eastern Mediterranean region and the Southeast Asia region, and most had large numbers of campaigns or outbreak responses in the database. And we narrowed the analysis of over 2,800 campaigns in the database by the years 2019 to 2023, the 7 countries. We excluded COVID, Ebola, and OPV2 campaigns, and we also excluded some types of outbreak response, such as polio, OCV, and MEN-A, although yellow fever and measles were included. Next slide. I'm going to hand this over to Eric. Thanks.
Thank you, Pratima. So to understand the algorithm, it's important to understand what we mean by a phase. So to us, a phase is a delivery of one or more interventions to a group of people at a specific time. And that's really the unit of this analysis. We're trying to find high quality phase pairings. So the first step is to just get the phases out of the campaign effectiveness database in accordance with the rules on the previous slide. So if you can picture each of these circles as a phase of a campaign, what we're really trying to do is find high quality pairings of these circles in a sense. Once we have all the phases out of the database, the next step is to actually come up with all possible combinations. So here we're pairing red to blue, red to purple, and then blue to purple. Once paired, the next step is to basically identify pairs that should not be combined together. We have a total of 10 infeasibility rules, or rules that phases should not be paired. 2 of the most common are non-overlapping geographies and incompatible start dates. So just for example, maybe the red phase and the purple phase actually don't have any common geography or no common admin ones. Once we've pared down to feasible phase pairs, the next step is to actually score the phase pairs. And that's actually done with a combination of the target population score, the start date alignment, and then the historical precedence of the proposed combinations. What we end up with is a score between 0 and 100%, where 0 represents a very, very poor pairing and 100% represents a very, very good pairing. So to get that, the target populations would have to be very aligned. The start dates would have to be on a very similar date, and then the combination of interventions for the combined phases would have to be very common. Once scored, what we want to do is run an optimization algorithm to essentially plan each phase at most one time. So we don't want to do double pairings, like pairing 1 with 2 and 2 with 3, for example. And we want to maximize the overall compatibility of the phase pairings that are suggested. So what we're showing all the way on the right here, the first case where we're attempting to plan 1 with 2 and 2 with 3 is actually infeasible because it would plan phase 2 twice. So our only options are to plan 1 with 2 or 2 with 3. And it turns out that 2 with 3 results in a score of 75%. And because of that, 2 with 3 is selected, and then 1 basically remains sort of unpaired. So that's the algorithm that we built to date. We think it's very extensible. So if there's feedback, it's very likely that we'd be able to change scores or adjust the way the algorithm works in certain ways. Next slide, please. Here we're just drilling into two of the more common infeasibility rules. So probably the 2 most common of the 10 feasibility rules that we've identified are geographic overlap and closeness to start dates. What we're showing here are just sort of visual representations of how these constraints end up working. The first, we may have 2 subnational phases. So each phase is targeting a specific set of admin ones as opposed to the entire country. But it is feasible because there's at least one admin one common within the phase pair. So in other words, they're targeting at least one common admin one. National to subnational works out fairly naturally because one is targeting the entire country. The second, therefore, must be targeting a subset of the country as well. The only time that phases would be incompatible based on geographic overlap is when they're completely disjoint. In other words, they don't even have a single admin one in common. And that would basically disqualify them from being suggested by the algorithm because there's really no place to plan the phase pairing. The other common reason for phases to not be compatible is actually start dates. So if the start dates are actually too far apart, planning can't essentially be done because one would have to move up too much or back too much in a sense. So the first example here we have on the left, the two phases have almost perfectly aligned start dates. So not only would this be feasible, but it would result in a score close to 100% for the start dates. In the second case, the earlier phase's latest start date is actually before the later phase's earliest start date. And because of that, we just can't identify a day for the phases to start. And so planning actually isn't possible because that violates our sort of 8-week window. We also do have disease-specific and campaign type-specific rules around these windows, but the sort of default is no more than a delay of 8 weeks or in advance of, or delay of 4 weeks or in advance of 4 weeks, resulting in a total of an 8-week window. Next slide, please. And here we're starting to get into results. So this is a very zoomed in view where we're just looking at 2 specific suggested code deliveries that the algorithm proposed. We're eventually going to move into the year-over-year view and the country view as well. But just to start out with, this is a very detailed view of 2 of the code deliveries that we found in the analysis. So this is looking at 2 code deliveries for Pakistan. But what we find interesting about this is that the code deliveries actually, in both cases, suggest the same set of 5 interventions. In both cases, essentially one phase that's delivering OPV is combined with a phase that delivers MCV, OCV, TCV, and TD. This is sort of interesting because that combination of 5 interventions has actually not been seen in our database before. And so it actually gets no precedence score. The algorithm did suggest this though, because there's a fairly good, or there's at least some overlap in the target population and the start dates line up. So in the first case, it's actually subnational to subnational with overlapping admin ones. And in the second case, it's national to subnational, again, clearly with overlapping admin ones. Both cases, it's 0 to 5 versus 9 months to 49 years. So clearly it is targeting the same people, at least to some extent. And the start dates line up very well. So the first case is August to August, and the second case is September to October. So essentially what we're highlighting here is that the algorithm can actually suggest novel pairings of interventions that may have not been seen in the campaign effectiveness database yet. Next I can basically turn it over to Andy for the year-over-year results and country results. Thank you.
Okay, great. Thanks, Eric. So the next few slides, we'll take a more zoomed out view of the results, and we'll go through what we found. So first here is just looking at the missed opportunities year by year. So looking from 2019 through 2023. And what the analysis identified is that there were 35 to 64% of the campaigns in the 7 countries had potential integration opportunities in the timeframe for the analysis. So in this graph, what we have on the x-axis is the year that the analysis actually happened, and then the year that the campaigns actually happened, and then the y-axis is the number of campaigns. So the blue bars are the total number of campaigns that happened within each year, and then the orange bars are the campaigns that had missed opportunities. And so you can see that for each of these, there was a number of missed opportunities within each of the different years. So in terms of, in 2019, for example, 63% of the total campaigns, or about 30 total, had missed opportunities for integration. One thing to note on this is that the number of missed opportunities tended to rise and fall depending on the number of campaigns that occurred within each of the years. So as you look at 2019, there were 63% of the total that had missed opportunities. That went down in 2020, where we saw 35% of the total campaigns had missed opportunities. The highest was in 2021, which also had the highest number of total campaigns. So here we saw 64% of the total campaigns had missed opportunities. Overall, there were 126 of the 240 campaigns we found had at least one integration opportunity. So this represents 53% of the total campaigns. In terms of the actual combinations or the integration opportunities themselves, we found a mixture of familiar combinations with some unusual or new combinations to our database. So what this graph is showing are the 12 most common intervention combinations that we found in the results. So here we have listed the 12 most popular, with the most popular over here, which is MCV and OPV. And then the 12th most popular is on the far right, with the MCV, OCV, OPV, TCV, and TD combination. On the y-axis here, we have the number of integration opportunities represented by each of these combinations. In total, the analysis returned 85 opportunities for the 7 countries within the time frame of the analysis. Of these, there were 56 unique intervention combinations, and 33 of them were unique to our database or hadn't been seen in our database before. In terms of the colors, what you can see here is that within the 12 most popular, we had vaccine-to-vaccine combinations. So the most popular example was MCV and OPV. We also had OPV and TD, IPV and OPV, and then the example that Eric went over before with the OPV combined with MCV, OCV, TCV, and TD. We also saw a fair number of cross-platform combinations. So things including malaria SMC with vitamin A, some NTD combinations with vaccines, and some other combinations that you can see in this graph here. The ones with the asterisks are things that were new to our database. And so a couple of these actually included malaria SMC with either vitamin A or also with MCV and Med-A. For a view into the countries that we focused our analysis on, this is the total integration opportunities broken out by country. So here we have our target countries on the x-axis, and then the total number of integration opportunities that were highlighted by the algorithm in the results. So you can see that Nigeria and Pakistan had the most. So Nigeria had 27 proposed integration opportunities. Pakistan had 19. And then in terms of the order from there, we had Guinea and India, followed by DRC, then Afghanistan and Brazil had one opportunity. This view combines what I had talked about before. So the 12 most common intervention combinations and the total number of those that appeared. So in the 2 slides ago, we showed basically these results here, where the total number based on the intervention combinations, but we're breaking it out in terms of which country these combinations showed up in. So here you can see that MCV and OPV was the most common combination proposed. And you can see that 3 of those occurred in Pakistan, 1 occurred in Nigeria, 2 in India, 1 in Afghanistan, and then 1 also in DRC. So this was this MCV-OPV combination was proposed for 5 out of the 7 countries within our analysis. A few other things to note is that in Pakistan, what we saw is that in general, there were more concentrated results in terms of, we saw higher numbers of proposed combinations within Pakistan. So 4 combinations of OPV and TD, 3 combinations of MCV and OPV, and a range of other proposed from there. In Nigeria, we saw a high diversity of combinations. So as opposed to there being 3 or 4 combinations of proposal of the same intervention combinations, we tended to see Nigeria being proposed once, say for MCV and OPV, or once for OPV and TD. And that continued for a range of the other interventions that were proposed. If you would like, once these results or the presentation is sent out, in the appendix, we actually have the full results of all 56 intervention combinations that were proposed, and you can see where those were, what countries those were proposed in. So the key takeaways, I'll hand this back over to Pratima to present.
Thank you so much, Andy. So in summary, you can see that this algorithm helped analyze optimal integrations among 240 campaigns from 7 target countries that occurred between 2019 and 2023. And of those, 85 integrations were identified as potentially optimal. And the algorithm helped identify both familiar and unusual campaign combinations. As Andy just highlighted, NCV and OPV, or measles and polio, missed integrations were common. And there were also 33 potential combinations that were not previously observed in the campaign database. And while this analysis used retrospective data, you can see that the methods could be applied to future prospective campaign data as well. And we could explore within immunization or other cross-program considerations to inform integration. And as we are now doing with all of you, and we look forward to hearing your feedback about this analysis. How feasible might some of these integrations truly be? Next slide, please. So just in terms of limitations, so obviously some key limitations include the fact that the algorithm can only optimize quantifiable characteristics that are included in the database. And we understand that countries may face very many additional limitations and such constraints, such as donor restrictions that may impact the decision-making about when to launch a campaign or which campaigns to be launched at the country level. And we also have to validate these findings with countries and disease-specific initiative experts. And we realize that all these findings may not be generalizable to all country contexts. And the data are also a potential limitation. The analysis is only as good as the campaign data that are included in the campaign database, and the completeness and timely availability of the planned and completed campaign reports can always be improved. And some campaigns lack data on dates in subnational locations. Next slide, please. I think we'll skip this one. So finally, here we are in our next steps and consultative engagement. We really look forward to hearing from you about your thoughts on this analysis and to what extent the analysis rings true to you and how we can do better to integrate campaigns going forward. There are potential ideas here about would such a tool be useful at the country or regional level? And how can we integrate such analyses potentially into the collaborative action strategy and the package of decision-making materials that the Health Campaigns Effectiveness Coalition is developing. And I think that's all, and I'm turning it back to our facilitators. Over.
Thank you so much, my colleagues. I just want to maybe quickly highlight some of the key points from this conversation, and just really appreciate Chris and India for clarifying how the health campaign effectiveness collaborative action strategy clearly aligns with the IA 2030 strategic framework. And also want to appreciate Pratima and Andy and Eric for the detailed analysis on how this how effectively campaigns can be integrated to avoid missed opportunities. We are in the next phase now of trying to validate a lot of the analysis at country level through engagements with countries, with our focus countries to customize and implement the CAS. Now, before we go into the Menti discussion, we would like to open the floor for just very quickly for Q&A. I know we have a couple of comments or questions already on the Q&A box, but I do want to highlight one comment that was on the chat about how campaigns need to also be integrated with big catch-up planning. This is something that we are in discussions with countries like Ethiopia, which is one of our focus countries for the collaborative action strategy. So definitely those are some key things that are in consideration at country level. So just want to highlight that question, and I appreciate the person that shared that. We will open now to these couple of there are a couple of questions here. The first one is that I think this is from Jennifer Knapp. It's very interesting that there are so much analysis on the start date when experience has shown that many SIAs have been delayed multiple times, often more than 4 weeks. Why then is start date considered a strong feasibility marker? And she also said to further clarify, my concern is that aligned final implementation dates does not mean that the campaign planning timeframes were aligned. Would like to take this question. Yeah, okay, Anindya, go ahead.
Yeah, thank you, Jennifer. Excellent question, but two things. Please remember here we were doing a retrospective analysis, so we couldn't sort of rewrite history. So we took history as it is, and therefore the actual dates of campaign start dates were hard available data to us. And based on that, we analyzed, of course, if campaigns, and I'm not getting into details, if they're far too more than 4 weeks gap, and then we couldn't call it a missed opportunity. The question that you have asked is very, very relevant as we go forward. Do we pin our hopes on a plan and the start dates? And I would say, there can be various answers to that, but I would say that if two campaigns are being planned, which are close to start dates, may not be identical, or one or the other campaign can shift to come into the simultaneous window, but shifting has to be within a certain epidemiological parameters, which is we have used ±4 weeks. Other countries or other situations, this may change. This is just the first cut preliminary analysis. So then the next step, one can think of what other parameters are there, which makes these two campaigns or interventions amenable to integration, or it doesn't work. That is how we approach that. If any of my co-panelists would like to add to that. Thank you.
No, I think you answered that well in India. I think just wanted to reiterate the point that as we move to something of a prospective analysis, I think this is where we're interested in feedback from in country engagement, because I think there is flexibility that can be applied in terms of any sort of start date exclusion or rules that go around the start date. So I think that's something that we would need to adjust as we move from looking in the past to looking in the future.
Great, thank you, Anindya and Andy. The next question is from Sangeeta. So the question here is, other than geographic area dates, what other aspects were considered as a good measure of integrating the campaigns?
Andy, would you like to reply, or maybe we could go back to slide 9?
Sure.
I do have the full setup, so I could at least read the list if it would be helpful. So it's slide 37.
Perhaps you could highlight the maybe top 5.
Is this the one, Eric?
Yeah, that's it. So basically, if it's already consolidated, there's no way to do additional consolidation. Essentially, in a couple different cases, there were reasons that doses should actually be spread out. So I think vitamin A was 5 months between doses. NDA was 6 months. Yeah, PZQ specific timelines. IBM for IBM with ALB for DRC in Nigeria. OPV to OPV. Yeah, just ensuring that they start on exactly the same day, and then yeah, the disease specific start window. So with that with certain diseases, the start dates would be more or less flexible, essentially. Yeah, did any other panelists have anything to add or anything to clarify with this?
I think in terms of, oh, go ahead, Fatima.
Oh, sorry. Yeah, so basically this was taking very agnostic view of the data that were in the database and applying various various analytic rules to say, could these campaigns potentially have been integrated? And so these were some of the rules that were used. And over to Andy.
Yeah, what I was going to say is the goals for the analysis was to identify some combinations where ideally the considerations were how much of an overlap or geographically, and then also in terms of their target population. So the idea was that more compatible campaigns would be occurring in the same place and then targeting the same populations. And then in terms of start dates, because we're looking retrospectively, we used those as pretty hard start dates. What we wanted there was to find campaigns that were going to ideally start closer to each other so that integration could be naturally flow from there. And then the final piece of this was the precedence. So this was to look at, had these campaigns been integrated or interventions been integrated in the past? And then how often has that happened? And the idea there was that if those interventions had been integrated before, that there was likely some structural or administrative knowledge in terms of how those interventions could be combined together. So ideally, there was a overlap in terms of the target population and geography, the start times lined up, and then also there was history and previous relationships of working together in terms of integration with those interventions.
And also to answer the question in the chat, in the Q&A box about, was this specifically for house-to-house campaigns only? No, it was not. It included other types of, all types of campaigns.
Great. Thank you, Pratima, for noting that kind of tag-on question as well. I'm going to take over here and move us to the next question, an anonymous question about whether the missed opportunities were mostly for campaigns at the national or subnational level.
That's a good question. Eric, do you have we'd have to dig into the results.
I just pulled it up. Yeah, it's
Yeah.
about half. It's about half. So about half are subnational, about half are national for the optimal pairings.
Okay. So we'll move on to the next. There's about 3 more here. We had the next question from Christina. What are the primary reasons indicated for missed integration opportunities in Nigeria and Pakistan? Are these attributed to different programs within the ministries of health, different implementing partners, multiple donors, or other factors? This may be a question for a further discussion later on. Essentially, what are the top 5 root causes behind these misintegration opportunities? So if you have kind of quick reflections on this, I would say let's hear from the presenters, but maybe this is an opportunity for further discussion after our Menti poll as well. Over to you all.
Maybe I'll start by saying we don't know the answer to this question, because this is really just a cut and dried analysis of the data that were in the database. We haven't yet had a chance to discuss directly with our colleagues in the different countries for which this analysis was focused. And it's very possible we don't, while we're calling this a missed opportunities for potential integration, we recognize that there may be very good reasons at the country level why integration did not occur, and we want to understand that better. And if there are people from these countries online, we would love to hear in the chat perhaps your ideas, and also through the next exercises, your ideas about why some of these integrations may not have happened.
Great. Let's move to the next question for now. But again, if we want to discuss this further and hear other comments on that later on, and Pratima, to your point, if there are folks from Nigeria, Pakistan, or other countries that were included in the analysis, would love to hear from them later as we conclude the webinar. Moving on to a question from David. For malaria and NTDs, glad to note the opportunities highlighted for integration with SMC and ALB. I do note the lack of integration opportunities noted for ITNs and other NTDs. Could you explain the reasons those intervention combinations were not highlighted? And we might also type an answer here to spell out some of these acronyms for folks who are not of the malaria or NTD space. But panelists, over to the reasons that some of these combinations were highlighted and others were not.
I don't know that we actually know the answer to that either, but likely, as this was an algorithm, it's probably due to the assumptions and the decision rules that were put into the algorithm. That's sort of my guess. But Eric, Andy, or India, your thoughts on this? And also, I am not a malaria or NTD expert per se, so look forward to your thoughts as well.
So the bed nets are included in the database. I think the consideration from the algorithm's perspective and in the results is whether the combinations, whether there were actual combinations that were feasible or infeasible, and then how strong or strongly compatible they were with some of the other combinations. Eric, I know you probably have numbers and details behind why this might have happened.
Very, very high level. I'm seeing 415 proposed pairings, including ITM. Unfortunately, only 15 were actually feasible, and only a few of the 15 actually included NTDs. The main reason that they were not feasible was lack of overlapping geographies and incompatible start dates with other phases. So probably at this point, that's about as much detail as I can give without additional context. But that's what the data is telling me at this point.
Can I just jump in here, because this question is important to understand from the way we looked at it. You see, we were completely agnostic. We were not saying, when we went into this analysis, we did not take a position that integration is good or integration is bad. Mm-hmm. We decided on certain data parameters. We applied them to historical data. Again, that same question comes on the start date and others. So whatever has happened, and applied a certain set of principles, and then found out which were feasible, which were infeasible by those set of parameters. So therefore, it might have been that these interventions that are highlighted as not being highlighted the dates just turned out to be infeasible combinations by our data parameters. Now, as we go forward, we may change this. We meaning the global community may change and then say, no, integration is good, integration should be done. So you stretch from both sides and make these closer together so that you integrate. That's a decision for future, and that brings a different perspective, and not an agnostic perspective, but a decided knowledge perspective. We did not take that. We were completely neutral because we had not decided this question yet. I hope that makes it a little clearer.
Thank you, panelists. Reading through some of these other questions, I think Sangeeta will save your second question here in the Q&A for later for a more robust discussion. And I'm just scrolling through to see what other questions are truly clarifying questions before we kind of delve into a more robust discussion. This question from Estrella looks like it may be worth further discussion as well. So we may just close this clarifying question session right now with this final question here from Lucas, and the others will be addressed later. Andy, I guess earlier in one of your responses, you commented that the history of integration was also important. Maybe this was in consideration to, or in relation to some of the parameters of what was and wasn't included. So the question here is, does that mean if there was no history of previous integration, this would exclude possible integration?
That's a good question. It does not mean, so if there was no precedence or history of the integration, the algorithm still considered those combinations. So in fact, we often saw, I believe there were 33 instances where there were new combinations that we had not seen in the database before. So it wasn't deemed infeasible by any stretch. So, and in fact, proposed new combinations. The precedents just gave some of the more familiar combinations that have happened a lot in the past a little bit more of a boost. So for example, MCV and OPV were the most common combination that we had seen in the database. And so any of those combinations got a boost because of the familiarity of that combination between those interventions.
Okay, I think with that, Andy, it's a bit of a ping pong. Go back to you, but to move us on to our next portion of the webinar. Oh, Pratima, do you have another comment before we move on?
I think there's one more clarifying question from Lucas about the last one at 9:54. It says, a follow-up to my previous question about house-to-house campaigns. Maybe I missed it, but was the campaign strategy, i.e. house-to-house versus distribution points or others, a parameter for excluding integration propositions? And I do not believe so, but I will turn to Andy and Eric for confirmation on that.
Yeah, at this point, no, that was not considered yet. This is exactly the type of feedback that we could incorporate in the algorithm. It turns out to make the pairings more feasible or optimal. But at this point in the analysis, it has not been included.
Okay, thanks Pratima for catching that. And Andy, over to you.
Thank you. So what we'd like to do now is segue into a discussion through a Menti poll. So if you can please go to menti.com, and then what you can enter in is this use code of 4861-8156. You can also use this QR code to get there as well. And I'll transition over to from the PowerPoint presentation over to that poll, and we'll go through some questions that can help facilitate a discussion about use cases for this tool, and then any experiences that you might have had with campaign integration. So the first question is about what campaign domain or domains do you work in? And so this is just showing a word cloud of where some of the responses have come in. So it looks like there's quite a few who are working in immunization. Looks like NTDS is a popular field as well, malaria, but looks like there's a broad spectrum of domains here, from planning coordination to essential immunization, malaria and NTDs, big catch-up. Looks like there's integration, monitoring, polio, evaluation. Looks like ITN, I'm assuming that's malaria bed nets. So what we'll do from here is we'll move on to the next question. So when I move to the next slide, you should be able to answer the next question. And so the next one is, have you had positive or negative experiences with campaign integration? And here you can answer positive, negative, or both. We'll just allow for further responses to come in, but from the early get-go, looks like there's been both positive and negative experiences, along with also some positive experiences. Pause here for, go ahead in India. Yeah.
No, can I just ask you, so everybody has been able to access Menti, because this is actually, we are 55 attendance, more 50 plus, and then I'm just wondering, and I'd request all to participate, please.
There's some more responses that are coming in, so we're seeing a mix now of some have had negative experiences, a range of both. Looks like both is still going to be the most popular option, and there'll be opportunities to expand upon this in the next few slides for questions.
Andy, there was a comment in the chat that this question could use a does not apply option. That's a great point.
Sure. Okay. Well, we can assume any non-responses does not apply. It's good feedback. Okay, why don't we move on to the next slide? And this is a question about what barriers or challenges have you encountered with campaign integration? And here you can enter in responses. So here we have a range of responses coming in and about coordination of finance and supplies, also with people. Polio seems like integration about priority in polio. There's also different funders, poor planning as well. Looks like a lot of this is coming down to planning issues and funding limitations, cooperation between the different kinds of campaigns, whether it's a geographical scope of national programs versus subnational. There seems to be some supply chain issues. Leadership and coordination seems to be a really important piece to this. So what we'll do next, as looks like some more responses are coming in, and after this, what we can do is we'll actually ask for your input on voting. So what we'll do, the next step is that you'll see these different options, and you can apply votes if you haven't entered anything into what you think are the most important or applicable responses. So what are the most important barriers or challenges that you see in the list here? But some more have been coming through, so looks like there's timing seems to be an issue. Either the lack of time or the resources to coordinate across campaigns. There are different coordination across different departments. Issues related to compensation for immunization teams. There's also stakeholder pushback. So all great responses. Thank you for your input here. So I think what we can do here is go into the voting. And so here, what you'll see is all these options, and you can place votes in what you think are actually really the most important or biggest barriers or challenges that you're seeing. So hopefully you should be able to see that you can vote on the responses that have come in. And once you place your vote, I think there will be a submit button. So be sure to hit that submit, and then that will tally your vote. So far, we have one person has voted, so we'll just pause here for a few more moments. I'm curious, Pratima and India, if you have thoughts about some of the responses on the barriers and challenges that were shown in the previous screen.
I noted in the previous screen that someone mentioned that there are also barriers from inside the country because of the cold chain reuse the same system or from within programs. So that was, we need to kind of put these in buckets, that the different barriers, external to the country, internal to the country, financial, etc., programmatic, etc.
Yes, I noted that a lot of the challenges were related to donor and financing, donor issues, financing, different funding restrictions, challenges with reporting across different programs. So a lot of sort of maybe self-imposed constraints and limitations based on each individual program need. It was also interesting to see that there may be disincentives to integration at the health worker level, or maybe at the district level, because oftentimes health workers are paid for these campaigns, and so they want more campaigns rather than fewer. And I'm certain that these issues have been also identified during the Health Campaign Effectiveness Coalition's work on campaign integration in the run up to the development of all these materials.
Okay, let's take a look and see what the results are in terms of the most important barriers or challenges. So looks like the most popular was the coordination of finance, supplies, and also people. Logistical issues and financial difficulties and timing was also quite a popular response, followed by different funders and any sort of restrictions that might come from the funding source. And then there's poor planning, the planning session of coordinating across the different campaigns. Great, so we'll move on to the next next question is in terms of a tool that we've just presented. So if you can imagine some kind of a tool online with an interface of identifying compatible integration opportunities. Question here is, would you use a tool like this going forward? So a range of responses are coming in where we have yeses and then also a couple of not sures.
I think we'd really also be interested to hear, if possible, either in the chat or in our discussion, where do you think such a tool would be useful at the country level or at a regional level, and how it could be used?
Yeah, well, there'll be an opportunity in the next slide or two to talk
Mhm.
about how to use this in the context. So you'll have a chance to provide your opinion and feedback on that. Okay, so it seems there's a number of responses in terms of that this tool would be useful. A couple where it's not sure, but we'll dive in, dig in a little bit more detail about how this would actually be useful and in what context.
And Andy, there's a question to restate what the type of tool is. Maybe just could you restate that?
Yes. So the tool would essentially run the algorithm that we've developed. So in terms of there being an interface, what we envision is that it would allow you to enter in potentially the details of, say, your a campaign, and then the tool could run the analysis and could come back with potential integration opportunities. You could also look at, so you could do that for an individual campaign, could also do it for a number of campaigns going forward. So if you were looking at more of a holistic view of all the campaigns that were planned for a country or a region, you could look to run all of those and then come out with the optimal pairings that would optimal pairings that would essentially find the most compatible groupings between the different campaigns looking in the future. So there can be different scopes. So it could go all the way down to an individual campaign, but it could also look at a number of campaigns as well. So in this question, we're looking, if you are interested in using this tool, how would you use it and in what context? So here we have a range of responses. So planning and working with stakeholders, talking about the flexibility of the tool, and it can include some contextual description of the scenarios. Considering the modality, so house to house versus fixed site, and then also the vaccine type, so injectable versus oral. Comment about analyze the savings coming from the integrated campaigns. So I think in terms of the next steps, what we really view right now, this analysis is that an algorithm is that it's, I call it an initial prototype or even a proof of concept of finding the most, the optimal pairings of integrations going forward. And I think what we're really interested in is one to align with countries in terms of the feedback in terms of, do the results make sense? Are there other considerations that we should pull in? And particularly one of those is any sort of cost efficiencies or effectiveness that might come out from proposed integrations. So I think that is certainly something that we could include in the next iteration. So other comments are looking at more for long-term planning, looking for future campaigns, not past campaigns. That's also a consideration that we would like to work on in the next iteration, is reorienting from a retrospective analysis into something that's prospective. I think there's a plug there for keeping the data as up to date as possible within the campaign hub, because the analysis and results will be as good as the campaigns that are in the database. But that's certainly something that we would want to extend the analysis to. So we have drive decision-making as a decision-making tool for the integration based on data. Last-minute outbreak response. See if it could capitalize on any planned campaign. That's a good suggestion. And then there's national level strategic planning. So what we can do here, similar to what we did before with the range of responses, is that we'll start a voting period. So you can look at all the different responses and vote on the ones that you think would be the best use case or context in your domain. While votes are coming in, curious from the other panelists if you have any reactions to the responses that we're getting. I think that was a targeted question, maybe for Pratima or in India.
Sorry.
Yeah.
Yes, apologies. No,
Quite all right.
I think it was I think it's really interesting that people are eager to see the tool be used for prospective planning and for potential savings, cost savings that could arise should these campaigns be integrated. So that gives us some fodder for thinking about how the tool might be modified going forward, and that costing piece it might be very important. Again, the tool will have to depend on the availability of timely and accurate, valid information on all the campaigns in a country, and that is often a rate limiting factor. The retrospective analysis we did, I think, didn't have those problems because a lot of the data were, probably more populated. But for a program manager that's thinking about what should I do with this campaign, they may or may not be. So if you're an immunization program manager, are you going to know what is happening with your malaria program colleagues? Are you also going to know about what might be being done with your NTD colleagues, by your NTD colleagues, and will all of that information be somewhere accessible to a host country? I think the Health Campaign Effectiveness Campaign Database is a good tool, but it will depend on the donors and partners populating information in advance, so that countries could potentially use that information. So I think that's a major uncertainty, and we also are hoping that this database will continue to be supported and by the international community. And India, I don't know if you have anything else to add on that.
I think what we heard today didn't really see the participants, and thanks everybody. What we heard today was actually there is an interest. I mean,
yes,
deposited, and now is the time to, I think, go forward and start applying this, make mistakes and learn it together. I very much take the point of that cost data to come in so that we can actually demonstrate, make a use case, whether this is cost efficient, programmatically efficient. We know Malawi has done a complex lot of interventions together, and they had shared their experience with us. So going forward, I think there's really an interest in doing this, but doing it well. But I do not anticipate that we'll be able to do it right the first time out. Yeah. This is quite a complex thing, but I think we need to start forward, and that's the mandate I'm getting from this audience, that let's better do something. The other point that Pratima made, I fully second that, is the other side of it. Just as we as a group look at this, the data have to be put in. So there needs to be some planning, because we cannot look at it on a blank slate. So the country program managers, partners need to put together something that we are having these campaigns at X time or Y time or Z time, and then so that we can plan ahead and do it together. The other thing that I learned is that it is true, and we knew this before we did this analysis, that there is a donor compulsion, there is siloed funding, etc., which could be constraints. But we also heard today, and it was a little bit surprising to me, but that's a good lesson for me, is that there are also constraints from within the country programs, that different programs need not we should not take it as a given. Even within MOH2 programs are happy to collaborate and jumping up to do that. So there might be constraints to that, and we need to negotiate on both fronts. That's two for me. Those are the lessons. Thanks.
Let's take a look at the results and see what the most popular use case for this tool would be. So it seems the most popular is to look at the potential future campaigns, so a prospective analysis as opposed to a retrospective that can help then with funding and planning. So I think that that is the most popular, but then followed by the planning and working with stakeholders, including modality, so house to house versus fixed site, and then also the type of vaccine, so whether it's injectable versus oral. I think that's a good suggestion in terms of some of the training that might be required for administration of those different vaccines. And then interestingly is the outbreaks. So what other campaigns we can piggyback on and integrate when there's an outbreak response. And I think here we can certainly adjust the campaigns that were considered, that we consider in the algorithm. So before in the retrospective, we had excluded a number of outbreak responses, but we can certainly include them in any of the next iterations of this, because I think that use case is potentially very useful and interesting in terms of if there's an outbreak response to find other campaigns that are actually ongoing or happening very soon that they can then add or jump onto. Okay, please go ahead.
I wanted to highlight also something that was on this previous slide, if you don't mind. I think there were some examples here of that on lower on this, on the potential use of this for national, even though there might have been fewer votes. I think these are still important points. You know, the use of the tool for savings and the use of the tool for national level strategic planning and grant application. I think that's also, those are good suggestions as well. And then the idea that the tool should be able to run by country planners, not just at the headquarters level. And I fully agree with that as well.
Yeah, I think our goal for the next iteration is to essentially align and also, you know, fund the development of this into something that can provide practical answers and have applications that would be useful in the field. So whether that's incorporating cost effectiveness, even maybe if there's any coverage benefits that might come from integration versus not integrating, identifying, you know, outbreak responses that might be able to jump onto some other campaigns. So I think what our priority is to tailor the algorithm so that it provides practical insights for use in the field.
Thanks, Andy. Thanks, Pratima. I'm conscious of time. We have about 10 more minutes left, and we still have some questions in the Q&A that we would like to address. Perhaps we could, if that's okay, so that we can.
Yeah, I think we can certainly transition back over to a Q&A. The remaining question was any sort of changes that could be made to this tool, and I think we've covered some of the changes. I think, you know, incorporating costs, incorporating outbreak response, looking more prospectively than retrospectively. So I think from here we can transition back over to more of a Q&A and discussion.
Wonderful. Thank you very much. So we do have, I want to encourage all of our participants to please add more questions to the Q&A if you have at this time. While we wait for additional questions, there's one from Christina, and it's essentially asking for the top 5 root causes behind missed integration opportunities in Nigeria and Pakistan. And just really what are some of the attributing issues to this? Could be MOH, difference in implementing partners, multiple donors, or other factors. It would be great if we could get one of our panelists to address this question.
Yeah, I think we mentioned that we we don't actually have this information at this point, because we have not, this has just been a sort of in a database exercise at using existing campaign data. We have not engaged with the countries yet. So we do not know what the top 5 root causes are, but I love the way that the question is phrased about what are the root causes for these missed campaign integration opportunities. And I think that's the next set of discussions we need to have with countries. I don't know if there are colleagues from any of the countries that we included in the analysis, and if they may want to chime in on the chat about what might be some of the barriers that they see in their settings. We'll have to talk more closely with the country programs to understand why this campaign may not have been integrated with that campaign. So we'll have to do some deeper dives with the country program managers.
Patricia would like to respond, or she's writing here.
I think Patricia is just helping indicate that that it will be answered live by the panel.
Okay, that's right.
Okay.
So yeah, go ahead. Just to add to, I mean, we didn't dig into those factors, but those are important. That is the next level of inquiry, next layer of inquiry, actually. Yeah, the root causes. Yeah, over back to you.
Thanks, folks. We're doing a carousel here as we're troubleshooting technical challenges in the background. That always happens, right? So I think let's move on to this question that's in the Q&A. And I think, as others have noted, if there are final kind of, things that the participants that you all are thinking about right now or questioning or want to talk about, now's the time to add those to the Q&A. And this question here from Sangeeta, she notes that there's integration of services of separate campaigns. Is there a plan to actually consider building algorithms that consider adding services that also target adults who bring children, such as family planning? Oh, there's a couple layers there. I wonder if our panelists have any thoughts on that.
So I would say that building these algorithms takes time and resources, and we've been very fortunate to have Andy and Eric's time to develop this algorithm. I think a lot will depend on additional resources being available to do these types of data science work. It's pretty labor intensive. But I think the ideas about integrating other campaigns that may not be currently included is a good one. We would have to have a data source for those campaigns, and I am not certain whether the family planning campaigns are included in the current HCE database, and I would look to my colleagues from Health Campaign Effectiveness Coalition to address that.
Can I, just before
Please, yeah.
Andy takes it up, let me jump in here. Let me get back to some basics, because remember at the beginning we defined campaigns. That means a time-limited, time-circumscribed intervention. So if there's some regular services being provided, we did not get into that because that's a different layer of health programming. And if family planning services in any country was delivered as a campaign, we did not, if that data was available to us, I don't think we excluded that, but maybe we didn't come across that. So that family planning services being delivered as campaigns, as far as I can remember, but Andy and Eric.
I'm not aware of it being included in the data, but if it was added and included in the data, we can certainly incorporate that in the algorithm going forward.
But maybe more from a service delivery perspective, rather than thinking about the data analysis and the tool, maybe that's an area for encouraging future discussion and dialogue, say between immunization programs that are thinking about life course issues, and thinking about which other health services are also reaching those populations, and how can we potentially bring those services together to better serve those communities. And I think that is a very worthwhile dialogue to have in country. I'm not sure that algorithm-driven approaches in that case are going to yield as much as having the conversations in country between the different programs.
Yeah, great points. And Sangeeta came in the chat with kind of a similar comment. I know, Sangeeta, you've done health campaign focused work in Rwanda, and note that in Rwanda, they provide family planning as part of their integrated campaigns. And I think that's really what we're hearing is that, you know, the priorities, and Pratima, you were just commenting to this point as well, the priorities vary in different country contexts and even subnationally. And this is one of the things we've also heard from colleagues. I'm thinking particularly of some of our colleagues that we're working with in Nigeria as we launch the planning and kind of customization for the collaborative action strategy in Nigeria. And an initial point of feedback for them is the HCE coalition really focuses on these 5 campaign domains. And they said, well, what about all of these other ones that are also related and within similar departments in the ministries, et cetera. So there's really that need to customize per the context. And I think that Christina also put this in the chat related to Sangeeta's point here is this kind of what is included or not, the scope, I think. Is it because some of these interventions are part of the same departments in the Ministry of Health? So for example, the example here is the maternal, neonatal, and child health divisions, et cetera. There's another comment here in the chat that I'll read off from Laura. The most important thing is a need to strongly consider acceptance of integrating different health interventions. And I see nodding heads from Pratima and Anindya as well here. We are basically at time. I know that there was a final comment in the Q&A, and I'll read that off, and then I think we'll wrap up. I'll look to the panelists if you have any closing remarks. So this final comment in the Q&A here from Lucas, not a question, but maybe a suggestion as a follow-up on the comment regarding engagement with country teams. I love this theme that we're seeing in these closing remarks. It could be useful to clarify if the newly identified combinations for integration that weren't seen historically are actually realistic, and if not, what the prohibiting factors are, and then adapt the algorithm accordingly. That's a great note to end on, I think. I'll also ask, as the panelists have any final remarks, that Andy, could you put your email in the chat for folks? That's a good way for folks to follow up. We'll also put in folks can contact the HCE Coalition, that's our team, and we'll liaise accordingly at campaigneffectiveness@taskforce.org. I'll type that in now. Panelists, any final remarks?
Nothing except to thank everybody, and I'm very encouraged by the participation and the interest that this needs to be taken. I get a clear signal that needs to be taken to the country level, actually applied, and more learning there.
Agree with Anindya. Thank you everyone who's participated and given your feedback and thoughtful input. We'll definitely take all these suggestions into account for the next phase of the analysis and the discussions with the countries. Really appreciate the interest, and it's giving us new directions for the future. So very much appreciate the opportunity, and also to Health Campaign Effectiveness Coalition for organizing the call. Thank you.
Thank you all. Have a great rest of your day.
Okay. Bye.
Thank you.
Everybody.